the IAP Delhi and the various accredited DNB institutes all over India. So the primary, this is targeted for postgraduate students and our faculty who are interested in listening to different aspects of newer developments. So this Thursday, we have Dr. Janani Sanskar. She is the chief of director of the Kanchi Kamoti Children's Trust Hospital at Chennai. She has a lot of credits to her. In fact, she is the real doctor with a PhD degree. She has a diplomate of national boards in pediatrics, and she has held various positions in the central IAP, in the state IAP, and she is an expert member of the community for WHO guidelines, who have framed for the dengue guidelines. And in addition to that, she has a lot of indexed publications in various journals and about 10 textbook chapters. Her primary area of interest are in hematology, rheumatology, infectious diseases, and emergency medicine. So I would request Dr. Janani to start. If we have I think by this time, Sushil must have tried to put the slides together. So I'm just waiting for the IAP office so that they can share her presentation. In the meantime, you can. Oh, you're muted. You are muted. Unmute.
Okay, I'm sorry about this technical glitch.
That's okay. Doesn't matter. Yeah, it's your. I think your presentation is here.
Yeah, it's there. It's there. Okay, I can start now. So,
Sushil, you can make it full screen if it is possible. You can make it full screen. Yeah,
yes.
That's fine.
Okay.
Thank you.
So someone will operate the slides for me?
Sure. The IAP office guys will be operating. You can say next. They will be.
Yeah. So thank you, IAP Delhi and Dr. Dinesh Paul and Dr. Anupam Sachdeva for the opportunity. So I just thought I will talk about the changing faces of FUO, or pyrexia of unknown origin. It continues to be a clinical condition which defies technical advances in diagnostic modalities and the expertise of the clinician. Next. So these are all various, next slide, please. Yeah, so you know that it is a challenge always whenever you have a child with a prolonged fever. They would have gone to different hospitals and they would have done all the tests, and then finally the ball is in your court for you to make a diagnosis. So the parents come to you with a lot of hopes, and it is really challenging. We'll go through a few challenging cases of PUOs where we got the diagnosis. Next slide, please. Yeah, so the first scenario is 13-year-old adolescent girl, high-grade fever for 1 month with excessive sweating, no other red flags. There was no history of contact with tuberculosis. Next. She was a thinly built girl who was weighing about 40 kg. Next slide, please. There was no pallor, icterus, edema, or rash. Joints were normal, except for a few mobile, non-tender cervical nodes. There were no organomegaly also. Next. Baseline investigations showed leukopenia, a mild thrombocytopenia. Next slide, please.
Next slide, Sushil.
ESR was 70 millimeters per hour, and there is a mild transaminitis and a mildly reduced albumin. Next slide, please. So, what possibilities we had in mind? What next? An adolescent girl with prolonged fever and leukopenia, mild thrombocytopenia with not much of clinical findings. We are not able to come to it. We can think of tropical infections. So then we went ahead. Next slide, please. We went ahead and did Manto, which was 20 millimeters positive. Next slide, please. I think ask them to quickly move. No?
Yeah, sure.
Ultrasound showed numerous enlarged mesenteric, porta hepatis, and bilateral iliac group of nodes. If you can see the X-ray, There is hilar adenopathy also. So the RGJ was negative. The laparoscopic lymph node biopsy was done, which showed MTB low detected, risk sensitive. And next slide, please. Lymph node HPE showed a caseating granuloma. She was started on ATT, fever settled. So the message from this, the final diagnosis was, next slide, please. Newly diagnosed, microbiologically confirmed, disseminated tuberculosis. Next slide, please. Next slide, please. So the lessons learned are chronic infections like TB can still present as FUO. TB and lymphoma can mimic each other. Suppose the same child had had a negative. No, no, no. This previous slide only. Previous slide. Sorry. Yeah. Next, next, next. Next. Yeah. Stop here. Stop here. So if the same child had had a negative manto, you should definitely get a lymph node HPE done, lymph node biopsy, and a histopathological examination is a must. Obtain tissue diagnosis. Do not start empirical ATT because lymphoma can mimic tuberculosis so much. Next slide, please. So moving on to the next case, a 9-year-old boy, fever of 3 weeks duration with abdominal distension for 1 week and breathing difficulty for 2 days. He was febrile, tachypnic. There was mild pallor, generalized lymphadenopathy, moderate hepatosplenomegaly with normal joints. Next slide. Total count was, no, this is not the next slide. Previous one, previous one. Is this the next one? Next slide. Oh, order is a
So
little
this is a
different.
girl, a 17-year-old. This is about
Oh,
an
no, no, no.
11-year-old girl.
Okay, okay. Okay, fine.
This,
I'll read from here only.
this is an 11-year-old
11-year-old
girl
girl.
with a development
Yeah, yeah.
with
Okay,
gluteal
previously,
region
well,
swelling.
yeah. She had a painful swelling in the left gluteal region with limping gait for 20 days and also fever for 20 days, high grade fever. A week later, a week after the fever, she also developed weakness of both lower limbs. Next slide, please. So she was hospitalized elsewhere for this gluteal abscess, and they had tried to do an MRA and drain the abscess. Next slide. So left gluteal abscess, prolonged fever, acute onset paraparesis followed by encephalopathy. So the DDs that we had was meningoencephalitis with para-infectious demyelination or cold abscess in the left gluteal region with CNS involvement, or the abscess is totally unrelated and she is having a GBS because she started having a paraparesis. We did not know whether it was just a starting of an ascending paralysis. When we went ahead and did the counts, we had a high total count with polymononuclear predominance, high CRP 113 and ESR 95. Um, CSF showed a low sugar and a high protein with a lymphocytic predominance. AFB was negative, cultures were sterile. MRI features were suggestive of Adam. Next slide, please. Yeah, this is the MRI showing those bright white areas, which was suggestive of Adam. Next slide. So this is a non-enhancing T2-weighted hypotension in the spinal cord also was involved. Next slide. So we had a consultation with a neurologist, IV specialist, radiologist, and then we thought we'll go ahead, treat her with meropenem vancomycin and also start on pulse MPS for the ADAM. Next slide, please. So there was not much of improvement. These are the repeat MRIs. Next. So the new worsening lesions were there in the brain, resolution of spine lesion, high inflammatory markers, persisting fever is still there, no improvement with NPS and meropenem and vancomycin, lymphocytic pleocytosis, high protein prevailing even in the second CSF. Next slide, please. Yeah, we went ahead and did all the second line, all were negative. Brucella, mycoplasma, toxoplasma for fungal infections, TPHA for uh, then NMO, CSF, ADA, everything was negative. Next. So further workup, we did a bone marrow. Bone marrow was normal, ANA was negative, IG profile, MBG, flow cytometry, everything was negative. Next slide. So we were wondering what to do, worsening demyelination, whether we should go ahead and give IVIG or do plasmapheresis and antifungal too, because the child was not improving. Next, this is the spiking temperature, and almost 4 cycles of plasmapheresis was over. Still no improvement. Next slide. So we were wondering whether we should just go ahead and continue plasmapheresis or stop plasmapheresis and continue antibiotic, antifungal, and ATT, or go ahead with repeat imaging. Next slide. So repeat imaging, to our surprise, it was totally different from the previous MRIs. We had numerous small ring and nodular enhancing lesions in both cerebral, hemispheric, parenchyma, sulci, everywhere. It was studded. The whole brain was studded with lesions. Next slide. We convinced our neurosurgeon to do a USG guided brain biopsy. Next slide. To our surprise, it was Burkholderia pseudomallei, which is otherwise neuromyeliodosis. So the entire uh, reason for the child having continuous fever, paraparesis, and encephalopathy was neuromyeliodosis. The next slide. So the diagnosis was neuromyeliodosis. Next. So we went ahead and changed the antibiotic to ceftazidime and trimethoprim sulfamethoxazole, and she definitely showed improvement in sensorium and weakness. Fever subsided. She was discharged home on oral cotrimoxazole and doxycycline. So the message here is this is the same girl on follow-up. So the neuromyeliodosis will not respond to your conventional antibiotics. It requires ceftazidime and cotrimoxazole. Next slide. So 10-year-old girl, previously well developmentally normal, documented fever on and off for 3 months, intermittent high-grade fever with neck pain for 5 days, weight loss of almost 3 kgs in the last 3 months. Next slide. So no other red flags. If you can see, all the necessary red flags were ruled out. Next slide, please. So she was febrile. She had bilateral, firm, mobile, non-tender, significant upper and deep posterior cervical adenopathy. And there was otherwise she was okay. And mild hepatosplenomegaly was there. Next slide. So if you can look at the labs, she had a normal hemoglobin, normal total count, and platelet count. PSR was 80. Otherwise, her cultures were sterile. X-ray was normal. Ultrasound did not show any clues. Next slide. So persisting fever, when we repeated the investigations, counts were going up. PSR was going up. Next. So we thought we'll go ahead. This is the temperature chart. Next slide. So all the second line investigations were negative. HIV, echo, bone marrow aspirate, bone marrow culture, everything was negative. Next. So prolonged fever with cervical adenopathy and hepatosplenomegaly. We thought we'll go ahead with the cervical node biopsy, which showed reactive adenitis. Lymph node expert MTB was also negative. So pending Brucella IgM, we started her on doxycycline. Next. So Brucella IgM came positive. Next. So relook into the history, we found that the mother was giving goat's milk because she was losing weight. So that was the reason for the brucellosis. Next. So if you look at the lessons learned from 2 and 3, the first one was tuberculosis, the second was neuromyeliodosis, third one was brucellosis. So the lessons learned from these two cases are zoonotic infections and other rare infections like brucellosis and melioidosis are important causes of FUO, and proper history of animal exposure is important, and high index of suspicion is needed for early diagnosis. Next slide. Bone marrow culture is important investigation and workup of infections presenting as FUO, and tissue biopsy and culture is important. Yeah. Next slide. Yeah. 7 months old male infant, cough, fever for 1 month, loose stools for 20 days, skin rash for 10 days. So a child who's less than a year having prolonged fever, loose stools, involvement of the lungs also, sick looking child, BCG scar was present, multiple discrete nodules over the arms, thighs, and flanks. So skin is also involved. There was a cellulitis over the right thigh, mild hepatosplenomegaly. Next, yeah. So if you look at the counts, you can see a striking lymphopenia. For an infant, the lymphocyte count has to be on the higher side. But this child has a striking lymphopenia and hemoglobin which was low and transaminitis. Gastric juice for expert MTB was positive. X-ray showed an atelectasis of the left lower lobe. Next slide. So HIV ELISA was non-reactive and serum IgA, IgG and IgM were very low. Low cytometry for T and B cell markers suggested SCID, and this child had an HSCT done and doing well on follow-up. So it was a severe combined immune deficiency. Next slide. The lessons learned are unusual, chronic, recurrent, serious infections always screen for immune deficiency. Lymphopenia is an important diagnostic clue for immune deficiency. So when you have an infant with, sorry, coming back and forth to you with multiple system involvement, and if you have a lymphopenia striking, please suspect SCID, because early referral for a stem cell transplant is rewarding, and these children do very well when they undergo a transplant at a very early age. So 10 months old infant, fever with skin rash for almost 1.5 months. Next slide. So febrile rash over the palms and soles, no lymphadenopathy, no organomegaly. You can look at the temperature chart. Next slide. So this is the type of rash the child had as an infant with a 10-month-old with rash, non-itchy, blanching, erythematous rash over the palms and soles mainly, and prolonged fever. Next slide. So if you look at the counts, nothing major. CSR is very high and CRP is negative. There is a discordance between the ESR and CRP. IgG was very high, but other reports were normal. Next slide. Yeah, so the red flags were these, the discordance between the CRP and ESR, a low hemoglobin, low platelet count, and a high IgG. This made us think of an autoinflammatory disorder. Next slide. So her DCT was 3 plus, ANA was 4 plus, Smith IG, UNRNP was strongly positive. So it was a monogenic lupus. Any infant presenting with lupus, always think of genetic disorder. So these are monogenic lupus, and they really, the prognosis is not really good, but they end up requiring and anti immunosuppressants for longer duration, and they can progress further. Next slide. So this is monogenic lupus. Next slide. So connective tissue disease, vasculitis is an important cause of FUO. Varied clinical presentation and multi-system involvement is the key for making you think of this. Negative CRP and a raised CSR is an important diagnostic clue. ANA is always a recommended screening test. Next slide. Moving on to the next child, 1.5-year-old male toddler, fever on and off for 2 months now. Admitted twice at different hospitals, treated as enteric and dengue. In one hospital treated as enteric, in another hospital treated as dengue because of leukopenia and thrombocytopenia. Again, he presented to us with fever of 10 days associated with chills and dryness. There were afebrile period in between these episodes of fever in the last 2 months. He seemed to transiently improve and then again had fever. So the third episode of fever he presented to us. Next slide. So he's a well-thriving, active and playful toddler. Pallor was striking and he had a firm hepatosplenomegaly, but no lymphadenopathy. Next slide. So his hemoglobin was low, his platelets were low, his total count was low. There was a pancytopenia with lymphocytic predominance, and peripheral smear showed numerous ring forms of and trophozoites of Plasmodium vivax and multiple ring forms and double chromatin dots of falciparum. So we were very thrilled that we made a diagnosis of dimorphic malaria, dual malaria. Next. Next slide, please. So we mixed malaria with severe pancytopenia, complicated malaria. We started him on artemether lumefantrine combination and gave a dose of primaquine after D6PD levels were demonstrated as normal. And he became afebrile. There was no malarial parasite on day 3 of admission and discharged home on hematinics and primaquine. Next. Then again, yeah, this is the temperature chart which just became flat after pyrimethamine and artemether. Next slide. He came to us 2 weeks later as OP. He was afebrile, but the pancytopenia was persisting. However, there was no malarial parasite on the peripheral smear. So we were wondering, okay, probably the bone marrow is taking a longer time to recover. We'll call him back a week later with a repeat CBC. The fever has subsided. Let us not worry. Next slide. A week later, he came again with fever spikes, persisting pancytopenia, and firm hepatosplenomegaly. Next slide, please. So this time, if you look at the trend of the lab tests, so his malarial parasites have disappeared, platelets are still low, total count is still low, and hemoglobin is still hovering around 6. So we thought we should not miss anything else. So we went ahead with bone marrow. Next slide. So HLH was negative, bone marrow aspirate was aparticular hypocellular. So bone marrow biopsy we did, and it was consistent with acute leukemia. Next slide. So it was the final diagnosis was acute lymphoblastic leukemia. Next slide. So the lessons learned from this child is persisting fever with cytopenia post-infection. Always consider secondary HLH or consider alternative diagnosis. When you have a child working up for pancytopenia, bone marrow biopsy is preferred over aspiration because aspiration smears can miss certain important details which can be fetched with bone marrow biopsy. Next slide. Moving on to the seventh case, sir. I have time.
Yeah, sure, sure. We have
Yeah.
till we can use 1 hour. We have around. We
Okay,
can do
I'll
it till
finish in
9 o'clock.
another 15, 20 minutes. I should finish.
You take your time,
Uh,
don't worry.
yeah. So scenario 7, a 2-year-old boy, fever of 1.5 months and skin rash of 1 month. Next slide. So a sick-looking, febrile child, and there was no pallor, bleeds. There was generalized lymphadenopathy, generalized erythematous rash, and a mild hepatosplenomegaly. Next slide. So again, we went ahead and did the usual battery of tests, high total count, hypoalbuminemia, transaminitis, all the viral markers, blood cultures, bone marrow cultures are all negative. ESR is 15, nothing, no clues from any of the investigations. Bone marrow is normal, echo is normal, ANA is negative. What are we dealing with? A child with a high counts, hypoalbuminemia, transaminitis, persisting fever, rash for almost a month. What is happening? We are not able to get any clues from all these tests. Next slide. So then we dug into the history. Always in PUOs, you have to go back and forth to the history because the parents don't think that certain things are relevant to tell unless you keep on asking them. So we went back and asked them any drugs you have taken, your child has taken. Then casually they said the child had a complex febrile seizure 2 months back, started on phenobarbital and valproate at the native place, which they thought was not important to tell us. So the moment we had that history, we made a diagnosis of DRESS, drug-induced rash, eosinophilia, and systemic symptoms. Next slide. So we went ahead and did a skin biopsy, which confirmed our diagnosis. Next slide. So this child improved with a short course of steroids. So the lessons learned from this child is in any child with FUO presenting with fever, rash, lymphadenopathy with visceral involvement, drug hypersensitivity should be considered in the differential diagnosis. Eosinophilia is not really necessary for you to make a diagnosis. It may be absent in about 10 to 50%. Next slide. 7-year-old girl again with intermittent high-grade fever of 1 month's duration, reduced appetite, weight loss is almost 2 kg in the last 1 month. She has altered bowel habits. Next slide. She's a fairly nourished girl with gross pallor, ulcer in the hard palate, painful erythematous nodular lesions in the lower limbs, erythema nodosum. Next slide. So when we looked at the blood counts, she had a pancytopenia, a raised TSR, a raised CRP, X-ray and ultrasound were normal. Next slide. So in the context of prolonged fever with erythema nodosum, with an ulcer in the palate and pallor, with raised inflammatory markers, we almost had a diagnosis in mind with altered bowel habits. We thought it probably could be Crohn's disease. After ruling out tuberculosis and autoimmune disease, we went ahead, involved our gastroenterologist, got a colonoscopy done, which showed punched out lesions in the colon, which confirmed the diagnosis of Crohn's disease. Next. So Crohn's disease, and she improved very well with azathioprine and steroids. So importance of looking always in a child with PUO, as I mentioned in the earlier case, importance of history taking and importance of physical examination is very, very important. You have to really try and strip the child and examine each and every part of the body so that you get some clue somewhere. Presence of oral ulcers, erythema nodosum lesions in a child with FUO, always think of Crohn's disease. Next. So I think come to the end. So diagnostic considerations in any child with FUO, think of in this order: infection first. First infection always first. Think of rare common things like tuberculosis, malaria, anthrax fever, rickettsial infection, brucellosis, uh, leptospirosis, and also keep in mind rare tropical infections like melioidosis. So infection should always be the first thing that you should think of. The next comes the previous slide, please. Previous slide. So the next one is inflammatory diseases. All your auto-inflammatory diseases like Kawasaki, your SOJIA, your SLE, your JIA, all that will come in the next set of differentials. Neoplasms, of course, lymphoreticular malignancies, lymphoma. Miscellaneous is like your monogenic lupus and other things. Of course, there is an undiagnosed category where we don't have an answer sometimes, like PFAPA and all will fall into that category. But now with the advent of genetic tests, you can always get a whole exome sequencing for these children with uh, causes which we are not really able to find out with all these tests. You will get an answer with your whole exome sequencing. Next slide. So always remember, FUO is always a diagnostic challenge. Remember, these children come to you after a month or two, so they're already burnt out physically, mentally, and financially. And the child is also frustrated because the child has been moving from hospital to hospital, lot of drugs, lot of pokes. So you're actually the final abode that they come to where they want to get an answer. So it is challenging. So meticulous physical examination, a detailed, thorough history, go back and forth every day, different parts of the day, ask them history to the caretakers. The main person, parents or the caretakers should be targeted. You will get very important clues from these history. Basic lab tests, do not forget to look at a good, look at the CBC, like clues like lymphopenia will make you diagnose kid. Pancytopenia will make you diagnose something to do with the bone marrow. So careful look at the total count and the CBC is very important. Basic lab tests like a peripheral smear study, your transaminitis, your hypoalbuminemia, all these will give clue towards the diagnosis. Targeted lab tests, after you do the baseline test, targeted lab tests like your echo, cardiogram, your HIV, your ANA, and your blood culture, bone marrow smear study, bone marrow cultures. These are all targeted tests which you do based on the clinical condition of the child. And of course, the treatment lies after you make a final diagnosis. Next slide. So these are some literature studies. There's a recommendation for updating fever and inflammation from a modified Delphi consensus panel. Next slide. So this is the
I think you muted yourself.
yeah.
Yeah.
So it says that if you can go through that, it says again same thing. You do the baseline tests and then the imaging, then you go to the molecular diagnostic genetic tests, and always go in order. Treat, group them as 12 groups: infectious, neoplastic, collagen diseases, benign, non-specific diseases like sarcoidosis. So this is a consensus which you can go through. I don't want to go through it. It's quite in detail. So again, it boils down to astute clinician who gets a good history, good physical examination, makes use of the lab tests to try to come to a conclusion and remains patient and gets the final diagnosis ultimately. Next slide. So take home points will be again ensure thorough history, examination, and baseline investigations. Panel, yeah, ensure all these are done. Return to the patient's history and examination at regular intervals. This is what I was telling. Every day when you do rounds, you please go back and ask, is there anything that you forgot to tell us? Please tell us something that you have forgotten. Go back, recollect, tell us. Consider non-infectious causes of a fever early in the patient's journey. All patients with PUO should have an HIV test. This is often forgotten. HIV now with the NATCO's help, I think we've almost pediatric HIV is almost gone. I don't know about Delhi, sir. How is it in Delhi?
No, it's not that bad as in Bombay or in the southern states.
We hardly see HIV,
We
sir.
hard, yeah, but
We
we
hardly
do
see
see
HIV.
not we see even in the upper class population, not only in the because of the result,
Maybe in
or
south, I mean down south, maybe it's there, but in Chennai at least it's not there.
yeah,
I
the
have not
perinatal
seen
has drastically come down, especially with
HIV.
the
Yeah,
maternal
correct,
ART.
correct, correct. So exclude malaria in patients with a history of relevant travel because of this migrant workers and people traveling everywhere. Even though malaria is almost eradicated, how about malaria, sir? We have almost no malaria at all.
We don't see in Delhi any indigenous cases of malaria, but whatever malaria we do get occasional spurts of
Very rarely, maybe one
Vivax
or two in a
malaria
year.
in Delhi, but whatever complicated malaria falciparum are from the neighboring states, for the MP, from Rajasthan. They are the areas where we get a lot of cerebral falciparum
Okay,
malaria.
okay.
So
We
they are
hardly see.
primarily admitted in the ICU with a lot of, but we
Oh
do
my
see
God.
occasional Vivax in the Delhi population, which
Okay.
more or less is not as now with the advent of monsoon we'll have dengue.
And
So
dengue will come here.
so
And a positive tuberculin or interferon gamma release assay is not diagnostic for tuberculosis. So don't start empirical ATT for any child who just has a manto positive. Try to obtain a tissue diagnosis. Try to obtain a microbiological confirmation before you start ATT. As I mentioned in the first case, lymphoma and tuberculosis can mimic each other. A negative manto does not rule out tuberculosis, and a positive manto does not rule out lymphoma. So both ways it can be. So try to get a tissue diagnosis, even if it's a laparoscopy, fine. Ultrasound guided or laparoscopic lymph node biopsy should be done. Next slide. Do not give empirical antimicrobial or steroid trials. Again, this is very important. In a child with prolonged fever and arthritis, do not treat like a JIA without doing a bone marrow because many of these children with arthritis finally will land up in the diagnosis of leukemia. So they've already received steroids, so transiently they do well. They think that they've improved, and finally they land up with a very bad, complicated state where we make a diagnosis of leukemia. So again, empirical antimicrobial or steroids not advisable. Be cautious with the interpretation of some serological tests as some perform poorly with high false positive and false negative rates. Don't go by the serology alone. For example, Vidal tube versus slide test. Don't just like the take Vidal and treat it like enteric. Viral can be positive many time, many months, even after the child has had an infection. And again, all these torch titers and your wheel Felix and all is now no role at all. Do not perform serological testing if there is no history of exposure to the pathogen that you are testing for. And always remember to do a PET CT early in the diagnostic journey of the patient because if you have no localizing clues, please go ahead and do either a CT test or a PET CT. Ensure that the patient is always aware of the strong possibility of no diagnosis being made. After all this, you should also tell the patient we may not be able to get a diagnosis after all these two. That's also you have to talk. Please be honest to the patient. and tell them that you're trying to your best to get the diagnosis. But sometimes we don't get diagnosis. We dump them as idiopathic for fever of unknown origin, remains unknown and unknown. Next slide, please. Yeah. So always listen to the patient. They might be telling you the diagnosis. William Osler's note. I think I'll stop there, sir.
Thank you. Thank you, ma'am. I'll try to look if anybody has. I don't think they have posted any questions. Let me see if. Oh, I think there are 4 question and answers. Let me
Okay.
read it out for you.
Yes,
Uh,
sir.
one student has put that, is Mantoux test done nowadays? This is
Yes, it is done. 2TU test is done. We are waiting for the Copenhagen test. It's still not come into in India. It is still not being used. So we still do Manto. IGRA is another alternative, but do not rely on Manto. It is a
yeah. This
baseline
is this.
screening
It's
test.
just a test of just tells
Yeah,
you about the
it just says
infection.
that,
That's all.
yes, yeah, correct. It doesn't say that the patient has a disease. It just says that the patient is exposed and has is a carrier. And always use 2TU and not 5TU. Yeah.
Okay. Then somebody has put from Sarthak, Dr. Sarth, how to do the brain biopsy.
Yeah, brain biopsy, you can do a burr hole if it is
A
multiple lesions spread
neurosurgeon
all
is
over the.
needed for that,
Yeah,
obviously. So
neurosurgeon is needed.
they
We'll
will
have to
do the
really
brain
talk to
biopsy.
them. Burr hole they can do and take a bit from the ultrasound guided they can do. CT or ultrasound guided.
Okay. So
We have
then
done at least 4 or 5 brain biopsies till now.
So, okay, then there's one more question. It says that many times we get MISC like picture, how to explain at the present when the COVID is not there.
I think COVID is not there now. We shouldn't
No, he
talk
wants
about
to
it.
say that we were associating, we saw a lot of MISC in the COVID season. So
Yeah,
now,
yeah,
see, you have to understand that MISC is primarily a pro-inflammatory response
yeah,
in response to certain infections, certain immunological conditions, certain rheumatological conditions. So a lot of, say, even an enteric fever can present a child with a sick with an enteric fever
yeah.
can behave like an
It's just a
MISC.
hypercytokainemia, that's
Yeah,
all.
it is a really a hypercellular increased cytokines are being pro-inflammatory response and you have to suppress it. So once you have ruled out an underlying serious infection, so you may opt for using IVIG or steroids depending on the guidelines. Okay.
Mm.
Then somebody has asked why the PET scan. She has already answered why the PET scan. So if you have a really diagnostic dilemma for a PO where you have ruled out most of the infectious diseases, the TB, the next comes lymphomas. So
Yeah,
occult lymphomas will be definitely picked up by the Hodgkin's. Non-Hodgkin's lymphomas would be picked up for the PET scan.
yeah. You can pick up things earlier than your CT. That's why you do it.
Yeah. Only thing is that PET would be at the completely the cost doing different investigations,
Yeah,
MRI, CT alone.
that will
So if
give
you
you
do
a
a PET
complete
scan
picture.
together, they may give
Complete
you an
picture.
answer.
Yes.
So what I would like to just, I think she has made a very crisp and concise presentation in highlighting the role of the bone marrow culture, which is very important. She has told us about the immunodeficient children can also present with PO. She has talked about the lupus, the various monogenic lupus, and the drug rash, the dress syndrome. That's very important. So do rule out underlying drug rash and a drug fever in children with prolonged fever. That's very important. One more thing is that whenever you are asking for an HIV testing, kindly do an HIV antibody test, not the spot test. You might miss sometimes the HIV on the HIV tri-dot test. So I would really suggest you do an antibody testing whenever you are asking for in this scenario. So I think we don't have any more questions. I think these are 4 or 5 questions I can see in the list of chat in the chat box. Thank you, Dr. Janani, sparing your valuable time.
Thank you for the opportunity, and I'm sorry for the technical
That's okay. It does
difficulties.
happen quite often with me. So
It has
I
never
can't
happened with
I
me.
can't get my slide sharing anyway. So it was wonderful to see you on this platform. So let's hope we have a next well coordinated session. Whenever you are coming to Delhi, you are most welcome to our hospital, Sir Gangaram
Yes,
Hospital.
yes.
So with this, I close the meeting. Thank you.
Thank you. Thank
Thank you,
you.
ma'am.